Well, thank you, Susan, and welcome everybody. Thank you to the Zomedica Corporation for sponsoring this. For those of you, I would like to just point out this is not a self-portrait. So, but so I think about the laboratory and veterinary dermatology, and there's a lot of things that we can do in our office that will get us answers very, very quickly. And um, and the other thing when we're going to talk a little bit about is some of the things about submitting tests and other things to help make sure we're doing the right thing when we're working up our derm patients. Just a quick look at this is my microscope that I use, and you can see it makes it very easy to see if the Demodex is there or not. Now, obviously, it's a scanning electron microscope, but the Demon, this is, you can tell this is a fully adult Demodex, the 4 fully developed the leg pairs. So kind of a cool picture. So I guess what I wanted to do is what kind of things do we want to see in-house and in our initial laboratory things? And the things, first off, skin scrapings, cytologies, and aspirates. And then we have some cultures that we often use. So skin scrapings, I think everyone feels pretty comfortable, at least they think they do, on how to do these and what we're looking for. And obviously the big 3 that we look for, Demodex, scabies, Clitella. In 38 years, I've yet to see a Piladera, but everyone talks about we should always look for them. So it is, that is, the small nematode, but again, never saw it in all my years. So when we scrape an animal, we want to make sure we're doing it properly. So we take our our area that we feel that we want to get our sample from. We want to gently squeeze the skin, and then we want to take our instrument, whether it's and again, I would urge you to make sure you dull your scalpel blades. Many times these are young dogs who are moving and stuff. I can tell you as a senior student, I watched one of my classmates slice an eyelid almost off of a dog by accident. So what started as a sort of simple skin scraping turned into emergency ophthalmology surgery to try to reattach this lid. Because so make sure your blade is dulled before you do your scraping, and you want to make sure you do it till you get the capillary oozing. One thing, these are skin spatulas. This is what I use, especially this one in the middle. And a skin spatula I like because you can get a very good sample. And most importantly is you cannot cut an animal with this. So I don't use scalpel blades anymore. I just use skin spatulas. And these are available through all the suppliers. I think, to be honest with you, and as this should be shocking to no one, I think you can actually get them on Amazon as well. I like to start my scans at 4x. And one thing when you're looking for mites is if you lower your condenser, it makes it a little bit easier to see them. So I will often lower the condenser when I'm doing skin scrapings, and I'll look for mites. And then if I find them, I want to do I want to evaluate what the mites are doing. I want to know what life cycles, what life stages are we dealing with? Are they alive versus dead? And this is important as we continue on therapy for a case. If we see a dog who has demodicosis and we scrape them, we see lots and lots of live mites. We see lots and lots of juvenile mites. We see lots of eggs. 4 weeks later, we're re-scraping this dog. If I'm still seeing live mites and lots of eggs, then I know we're not really making great progress. If I just see the occasional mite part or a dead mite, well, then obviously we think our treatment is helping. And just to remind you that the 4 stages of Demodex mites that we look for, 1 being the ovum, 2, a larva, you notice it just has 3 leg pairs, the nymph having 4, but not fully developed leg pairs, versus an adult with the 4 pairs all fully developed. So I do think it's important when I do my scrapes, if I see a positive, I'm putting down my life stages, my, what percentage is alive versus dead, and so I can evaluate that as we treat this dog. If we're scraping and we suspect that perhaps this dog has scabies, as you know, these are often very difficult to treat, I'm sorry, to find. But in this case, as we got kind of lucky, not only do we have a live mite here, but we even have a big live scabies egg in the same. So if you find either one, of course, you have a positive diagnosis for scabies. If, as you also remember, I'm sure, if you suspect it, treat for it. Now, I would say that with the invention of the isoxazoline and antiparasitics, we have seen mite numbers go way, way down, which is great. Because so we're doing good flea control, we're actually treating for many of the mites as well. But remember, we still see them. One thing we are seeing too is if you're using a combo, such as the Simparica Trio, the one that right now, the first one I think that came out, that the Simparica is lower than Simparica by itself, and we have seen breakthroughs on Simparica Trio, not so much on Simparica, but on the Simparica Trio with a lower concentration. And we want to make sure, that if a dog is on Simparica Trio, don't think, oh, he can't have mites, because then for sure they can. Cats, a little bit different. This is a cat, and then obviously the lesions are a little more subtle. It's an older cat who's got FIV and chronic diabetes mellitus, and we had this sort of hair loss area with small little areas of erythema. And this is a cat who has Demodex cati. Here we're seeing a case of Demodex gatoi. This is the Demodex that behaves a little bit more like a canine scabies mite. These cats, this is the one that's contagious. This is the one that's paritic. This is one that you would get in a cat who's not necessarily immune compromised like you would in a Demodex cati infestation. Just a close-up of Demodex gatoi. You can see the legs, but it has a very short, stubby tail. Show them side by side. Demodex cati, you see a very long, thin tail versus a short, stubby tail with Demodex gatoi. This is something that we don't see that commonly. This is Demodex ingi. This is we see this in dogs, and you can see this is an exceedingly long tail. I don't know how many people have seen it. I rarely ever see it. When I do see it, it seems to be in sort of a seborrheic oleosa case, especially in small like Shih Tzus and Lhasas and Bichons. Some of they're these sort of a greasy, often allergic dog. And we usually, like I said, I found it most commonly in like the dorsal thorax, especially between shoulder blades, sometimes actually on the head as well. For those of you who see exotics, this is a bunny, and this bunny obviously has this areas of alopecia. The bunny is relatively paritic, and this is what we see here is Chyliella parasitoborax, and the bunny. Remember that the Chyliella have these big pincer palps, and these are what they that hurts the animal, or sometimes we say in the host, the human host. They are species. They prefer their own species, but they will cross species. You can see you bring in an affected bunny to a household, those mites may very well not only go to the people, but they'll go to they could go to the dog or a cat as well. This is the owner of that bunny. You can just see all this, all these erythematous bites all over her stomach, often just like in scabies, sort of the high contact huggy area and stuff. And I will say this, I find that as a veterinary dermatologist, people love to show me their own lesions. And unfortunately, I've also found over these years, it's inversely proportional to how attractive they are. So unfortunately, and yeah, you can see here this woman is actually much more miserable than the bunny was. The bunny was pruritic a little bit. This woman was like out of her mind with itching. I don't know how many people are online who can see patients in the Houston area, but for a long time, this Houston was an area we had where this seemed to be a problem. But this is actually feline scabies or notoredric mange. And this in 38 years is the one and only case that I've ever seen. Yet my friends who are in Houston often said they would see it weekly. There seemed to be a hotbed. I think it's gone down over the last decade or so, but it does seem to be that just like in canine scabies, it can be transmitted from the animal to another cat. It can be transmitted to a human host. The one difference is typically, unlike in canine scabies, you usually can find these mites with relative ease. I don't know how many people are using hair plucks, but I find hair plucks to be very helpful when I am looking at cases with deep pyoderma, and especially the interdigital space and the pads and sort of around the pad area. Often very hard area to get a good scrape. A lot of times with cases of deep pyoderma, you're looking for blood. Well, as soon as you do the first, sometimes even when you just squeeze, blood starts pouring out of these. So knowing how deep to go often is tricky. So I do think that I like using hair plugs, especially for interdigital and or paw cases, pododermatitis cases. And here's a pluck, and you can see you can get a lot of Demodex mites coming out with those hair shafts when they have them. Let's talk for a second about cytology. And for me, of course, the big two that I use primarily are skin and ear cytologies. What I'm looking for is the presence of bacteria, inflammatory cells, yeast, and neoplastic cells. I'm sure most of you will use diff crank as my most common stain to use. The question of should you heat fix these or not, many of the clin path people feel like heat fixing is not necessary. I guess after doing it so long, I don't use a flame. I do use a hair dryer to sort of heat fix as well as for me. I don't actually use the fixative or the red stain. I only just use the dark blue or purple stain for my cases because I'm more so interested in the morphology and what is present. You can usually tell if it's if it's a rods versus bacteria, versus cocci bacteria. So, and I know that the ones that I'm concerned about, if it's a cocci, it's going to be gram positive. If it's a rods, it's going to be gram negative. And remember, this is not a gram stain, so it's up to you. Like, nothing wrong with doing all three if that's the way you like doing it. But again, it saves me a little time and effort just to choose the purple. What bacteria are most concerning? Well, by far, the uh, it is staph. Sometimes we think about strep, and and when we talk about in skin, but by far it's staph, and then yeast being malassezia as being our other big culprits that we're wanting to look for. And this cat, you can see, has a draining tract and the erythema and induration. This is sort of on the lateral elbow of a dog with lots of ulcerations on this dog. The sometimes people say, well, what do you do? Do you do, slide preps or do you do tape preps? And I think for me, I tend to do for moist lesions, I tend to do more direct tapes. And I always use two slides. I like to have a backing slide. I was involved at the med school when I was a resident at University of Pennsylvania, and I saw a human dermatology resident use one slide on a woman, and it broke, and the slide stuck into her, and she was not so happy. So I always use two slides. That way, you'll never have a slide break with you. And then on a dry lesion, a drier lesion, we'll use the tape. And just remember, please, no frosted tape. I cannot tell you how many students and interns would bring me slides to look at, and as I looked, I couldn't see anything, and I realized they'd use just regular frosted tape. You have to have clear tape for this to work. So, and this is the dog who is obviously has lots of allergies, lots of malassezia and staph infection, very seborrheic and oleosa seborrheic, very greasy dog. This would be one that I would use a direct smear, but you can do a tape prep as well. That's not the worst thing in the world. So I guess on close up, you can see all the induration, you can see all the erythema, there's even little papules, but this is a greasy dog. You just even got to feel just looking on this slide. And this would be a perfect case to just do a direct smear on. As opposed to this, I think you find this type of collarettes, you could, if you do a direct smear, it's not going to be nearly as rewarding as doing a tape prep. And this was just a case that we saw not that long ago, and it's like probably one of the best ones I ever got. But look at this keratinocyte just covered with malassezia all over it. And then here's again, just a regular peanut party. Notice these big round cells. This is a mast cell. These are the granulating mast cells. Again, this is not something you would do on a direct smear, but this is actually an aspirate. But this was a direct smear on a plaque from a kitty, and you can see this huge number of eosinophils all throughout this smear. So this is an eosinophilic plaque, part of the eosinophilic granuloma complex. For those of you who like dermatology, you may have heard this term, the Tzanck Prep. And that's sort of the aspiration of an intact pustule or crust or under a crust. And what we're looking for is hypersegmented neutrophils without bacteria and the presence of acantholytic cells. This is Arnaud Tzanck, who's a physician from the First World War, a French physician. He's the one who developed these, and it's very, very commonly used on the human side, not only for pemphigus cases, but a lot of the herpes cases as well. And this is a really good example of a positive Tzanck prep. You can see all these hypersegmented neutrophils, and what you don't see is any degenerating ones and any intracellular bacteria. And these brown, the fried egg looking things, these are the acantholytic cells. So switching gears a little bit, I think that when I work up an ear case, there's nothing more important to me than ear cytology. I mean, yes, the most important thing we always talk to the owners about is with ears, there's an underlying reason. So we have to figure that out and treat that. But when we're treating our ears, the most important thing for me to do, besides, of course, obviously my exam, is the cytology. And what am I looking for? Well, I'm looking for bacteria versus yeast. And on the bacteria, rods versus cocci. Are the bacteria intracellular versus extracellular? And I can't stress this enough. Ear cultures are controversial at best. I never culture ears. I know some dermatologists still recommend on some of the middle ear ones, they'll do it. But basically, I feel like, often the culture is misleading and often sends you down a very difficult path. Cytology, much more valuable. And for sure, never do a culture without doing cytology. What if you did a culture and you grow out, you came back with a report that had malassezia and you had no cytology, you would have no idea how to interpret that, because all ears have malassezia, all ears have staph in them. So if you knew that you had 4+ malassezia on your cytology, that might be different than not, same with the staph. If you knew you had 4+ intracellular staph and, uh, bacteria, cocci on your cytology, it would make the culture much more meaningful. Again, I never do cultures. I think we learn everything we need to know um, based on our cytology. And people say, well, that's just crazy. Doesn't Well, remember, this is really important, is that the sensitivity that people always ask about, well, it's not sensitive to anything. That's based on blood levels. It's not based um, on topical levels, which are much, much higher. So if it says it's resistant to an antibiotic, it doesn't mean that it's going to be sensitive and resistant to it in the ear. If you're pouring in it a much higher concentration, the blood levels would ever do. Also, based on environmental factors in the ear canal, sometimes the antibiotics just don't work like they're supposed to. So even if you were getting a full, the high enough level based on your MIC into the ear canal, doesn't mean it would necessarily work anyway. So I'm not, if you tell me I'm never going to culture another ear again, wouldn't hurt my feelings. I can't even tell you how many years it's been since I did one. I also think that sometimes we can be fooled. This was a case that it didn't look like it looked like it was going to be, it's an allergic dog. It looked like it's this sort of brown, creamy exudate. I thought, oh, this is going to be, one of these 3+, 4+ malassezia cases. And look below, this is a bacterial, slide with biofilm and degenerating neutrophils. So if you look at this culturette just grossly, you can be fooled. You need to roll it out on the slide and have, do the staining for it. Something I never see are ear mites, but I'm sure you do. And they are fun to look at. So, but again, this is another thing we might see on our ear cytologies as well. I said, and it's very rare for us to see it in a dermatology referral practice. An interesting case here, these very abnormal looking cells and lots of cocci. So they're sort of chaining. So these actually turned out these are strep and these cells, but these were cancer cells. These were this dog had a squamous cell carcinoma down its ear. And we were able to pull these cells out just by accident, but we were able to make a diagnosis of squamous cell in this dog just by looking at these slides. Again, lots of malassezia. Most of everyone has seen tons of these. But again, I also would say it's important to look at the numbers. I mean, you've seen this kind of numbers on a keratinocyte, these every which way. If you just saw one here, one here, one here, that might not be that's certainly not nearly as concerning. Well, Zomedica's did also do this because they're involved with digital microscopy. This is a prototype that we've been messing with in our office here. Zoetis has their own one that many people have started to use as well. But it's interesting to see if this may be the cytology for the future, and that we will end up having our cases read, either stained and processed for us, saving us time, sending it out to easily sending it to a clinical pathologist if there's any questions, especially on aspirates. Maybe certainly that's more important, and getting answers back so much more quickly than the normal way. So I think this is an exciting thing that we have for the future to work with. Now, we talked about cultures. But again, I said, well, I don't do ear cultures, but I do lots of skin cultures. And sometimes people say, well, it's sometimes they're frustrating and stuff. Well, sometimes we do our cultures actually in house. We have an incubator. We use a system. Oh, I just want to put this out. Make sure, especially for if an assistant or tech is doing it, they know how to how to handle culturette. And you laugh and you think, oh, that's the craziest thing ever. Until I saw one of my assistants years ago hand me a culturette that she had opened for me, and she was holding it right here on the stem. And I said, well, you can't touch there. And she said, well, that's the way we've done it for all those years that are my previous practice. And I thought, well, that might explain why you have so many positive staph cultures in its own right. So yeah, make sure they know this is the only place you can touch, and opening this very carefully and putting the culturette inside the medium for transport. If you're sending, he advised me, some labs are much better at cultures, especially skin cultures, than others. So you may want to look into that as far as, are you happy with your skin culture results? There, like I said, there are many good, really good micro labs for skin. For the in-house cultures, this is the color spot system that we've been working with, and it's very fast. One of the reasons we do like it is you get an answer back so quickly. I often will get an answer with the sensitivity back within 36 hours, which for me, in some of my cases, is really, really helpful. But it's limited. We only do eight antibiotics. Now I have my own 8 that I have sort of set up to use, and we're using the Kirby powered diffusion, not an MIC. So for years and years, people have loved doing dermatophyte cultures, and why they're fairly easy to do as far as doing the culture. Just want to remind you that it turns red as the proteins are metabolized, but this should happen within the first few days if it's truly a dermatophyte. Remember that the other organisms, the non-dermatophyte organisms, will do the same thing and turn it red, but they will take much longer, usually 7 to 10 days, and sometimes even longer. Also, dermatophytes are never pigmented, and they're never dark. I mean, they're not all white and fluffy like we'll see with the cases of Microscopic canis, but they're typically white or tan. So I've often had people, show me, send me a picture. It's like, this looks like a ringworm. It's like, and it looks like, like something that your bread would sitting out after a week on your kitchen counter. Blues and greens, I think that's no, the dermatophytes never look like that. So I actually also tell you, now that I with PCR being available, I think this is one that we should send out anyways, because we're not really trained as veterinary microbiologists. Now, this is a nice case of Microscopic canis. You can see the white fluffy colonies. You can see the red color change, which happened within like 3 to 4 days. But the problem with dermatophyte testing is, one, we now should speciate this. We'll show a couple of pictures. That's done through macroconidia and using often a stain like lacto-cotton phenol blue. And most people are not really trained to do that. And it's important sometimes to know not only that it's ringworm, but what kind of ringworm are we dealing with, because that might also tell us where we should be looking for, for the source. And this is the macroconidia with the stain. You can see more than 6 compartments. Lets us know that this is Microsporium canis, as opposed to this one, which is Microsporium gypsum, which 1, 2, 3, 4, 5, 6. So this is a soil organism. Often we see this infection on the nose of a burrowing sort of digging dog. And again, we don't want to blame the cat or someone else is causing this. If the dog is a digger and has ringworm on its nose, It's probably from this microswarm gypsum, not microswarm canis. Again, I also will tell people, and I've been guilty of it. So, you should you do dermatophytes in a sort of a dark place. How many people will put them in a drawer someplace, and then all of a sudden, a week later, they think, "Oh crap, I forgot," and they go and pull it out, and now you don't know when the red color change happened. And so, I think just take your sample and send it to your reference lab, a good your micro lab, and let them grow it. And then if it is positive, let them speciate it and tell you so that it can help you with further treatment and to get to the bottom of the problem. A couple other things, CBCs, most people with skin problems, we don't typically see lots of changes. One time what we could though see is elevated white counts in some cases with really deep pyodermas. We will sometimes see that. We may see, especially in cats, elevated eosinophils with allergic disease, especially with eosinophilic plaques. I think my record is like 68,000 circulating eosinophils in a cat who had really bad eosinophilic plaques on her tummy. And we could see anemia of chronic disease on some of the long-standing cases as well. Some of the dogs that we've seen with really exudative lesions may end up having low albumin, and globulin certainly can be elevated in these sort of inflammatory cases. And one of the things we always want to look for, ALT and ALP, alk-phos sort of changes, especially elevations. In case of a cushienoid dog, cases we sometimes need to be careful with if we're monitoring on some of our drugs that are hepatotoxic. So we definitely want to make sure we do those, either in-house or sending them out. Real quick, a thing about dermatopathology that I want to go is, one, unless it's a tumor, we never ever scrub a skin lesion. The crust and the superficial layers may very well hold this diagnosis. And look here, this is a very compact stratum corneum. If you scrub it, that's all going to be gone. Probably you see how thin the epidermis is. Now you're in the dermis. That you could easily scrub that right off. And if there's information right here, maybe in a Tzanck case, this is all parakeratosis. You want to know that. And so we never ever scrub a skin lesion that we're going to biopsy. And to do a biopsy, take a lesion, we want to make sure we use a sharp punch. These are not reusable. These are one-time use only. A sharp punch, keep the skin taut. Use a circular cutting. Some people say you can only do it by turning it one way. I, for all these years, have never done it that way. I do this twisting back and forth. But the other thing I just wanted to show is go until the punch is to the skin level. Bury it. Do not pick it up, look at it, then you push it back. That's just going to cause much more artifact. Okay, so just go ahead and make sure you get it buried all the way to the hub. Then with very fine 1x2 forceps, pick it up from the base. Do not touch this part. Pick it up from the base, and then use your metsomoms to cut from the deep in the base and lift it out gently. I usually blot them and then put them in the formalin. If it's really, really small, you may want to use a cassette, but mostly, And now the other thing is make sure we send it to a dermatopathologist. So pathologists, some pathologists, general pathologists at reference labs look at everything. So, they look at your skin case, then they follow it with a bone biopsy, then they're looking at lymph node biopsies, then they're looking at, and then they don't have time to learn all the nuances of skin. So always try to get, and I'm not saying just the derm path consult where a pathologist will review it and then you get a derm report too. I'm just talking about make sure that your pathologist is interested and good at skin. And you can ask the reference, if it's a big reference lab, it's not a derm path lab. You can ask for, I would like, who's the pathologist there who likes to do skin, who seems to be the skin expert, and they can direct you, and then just say request that person. So that's a very, very important. I will say this, just you handling these biopsies is critical. Yes, some people say, well, where do you select? And do an earlier lesion, an old excoriated lesion is not going to give you nearly the information that you would get if you did a nice erythematous papule or a really nice intact pustule. And sometimes I've done pustules that are so big that we've actually excised them just like we would do a tumor and not even used a punch biopsy. So also very important, but make sure and give them enough. Don't do one 3 millimeter punch biopsy with a crush artifact is going to guarantee you're not going to get an answer. So get them 2, 3, good size, 4 to 6 minimum. 8 is great. So the pathologist has a lot to work with. And this is a case of pemphigus foliaceus. Again, look how thin the stratum corneum is. These are these hypersegmented neutrophils, and in there also are acantholytic cells. You can see this epidermis is much thicker than it should be. But if you scrub this, you would have lost all of this. You would have just been looking at this area down here. You would not be able to make a diagnosis with that. Well, I know everyone hates to hear this, but I will just tell you this is this is from the Red Sea, half of Egypt. We saw this. This is the biggest nudibranch I've ever seen. It's about 2 feet long, and it was at night, and we lit it up with our spotlight. But really cool, really beautiful animal. I've never seen anything quite like it. But now we kind of have covered everything, and like opening it up for questions.